So guys, we discussed regarding the brachial plexus, right? So now we shall have a discussion about in detail discussion of about Erb's palsy as well as the Klumpke's palsy. Okay, so we shall be discussing right now about the Erb's palsy. Now when it comes to the Erb's palsy, few important things you need to keep it in your mind, that all of you know that Erb's palsy causes a type of deformity, and that is called as policeman tip or waiter's deformity, right? Or waiter's tip, policeman tip or waiter's tip. Okay, now all of you remember this important point, that if there is a lesion of upper trunk, that is called Erb's palsy, and if there is a lesion of lower trunk, that is called as Klumpke's palsy. Okay, so Erb's palsy is the upper trunk lesion, and whereas the lower trunk lesion will be Klumpke's palsy. Klumpke's palsy will be the lower trunk lesion. Okay, next important thing is that if you look the patient in case of Erb's, as well as if you look the patient in case of Klumpke, right? So what are the differences which you would find in these patients? So the differences which you would find in Erb's as well as Klumpke's are the first important difference. Okay, the first important difference is that, first of all, how does this Erb's palsy occur? Erb's palsy occurs when there is shoulder dystocia during delivery, right? So during delivery, if there is undue separation of head as well as shoulder, okay, if there is undue separation of head and shoulder, okay, so where do you see undue separation of your head and shoulder? In case of shoulder dystocia during the delivery. So in this case, okay, now for example, if you look at the Klumpke's palsy, right, how does Klumpke's palsy occur, guys? See, if I am raising my hand, this is called as abduction. Okay, if I am completely raising it, this is called as hyperabduction of the shoulder. So in case of hyperabduction of shoulder, now when does this hyperabduction of shoulder happens? The first important thing is that, for example, if I am sitting on the top of a tree and suddenly I fell down, right? So I am falling down from the tree. So when I am falling down from the tree, for example, let us say I have holded a branch of that tree. Now when I holded a branch of the tree, my hand will undergo hyperabduction like this. So completely I will be holding it like this, in this way. So this is called hyperabduction of the shoulder. So in case of hyperabduction of shoulder, when does this hyperabduction of shoulder happens? In two cases. The first thing is holding on to a branch, right, while falling from a tree. One is holding onto a branch during a fall. Okay, second important thing is that if there is a difficulty in breech delivery, if there is any kind of difficulty in breech delivery, so if there is any kind of difficulty in case of breech delivery, in this case also there will be hyperabduction of shoulder. So shoulder dystocia is one most important reason in Erb's palsy, and here there is hyperabduction. Now in hyperabduction, holding onto a branch as well as difficulty in case of breech delivery. Okay, not only that, the next example I would like to give here is, I would like to give in case of Erb's is that, for example, let us say there is something, right, if there is a heavy weight that has been fallen on my shoulder, right? Let us say I am sitting under a tree and a very big thick branch of the tree fell on my shoulder. So even in that case also I will have problem with the brachial plexus. I mean, I will have the problem with the C5, C6 trunks of the brachial plexus, which will lead to Erb's palsy, right? So another important thing is that, so if there is heavy weight fall on shoulder. Heavy weight fall on shoulder also will lead to this thing. Okay. Next important thing is that in the second important thing is in Erb's palsy, what are the trunks that are affected? I told you that would be C5 and C6. These are called as upper trunks. And here what will be the trunks that will be affected? That will be C8 and T1, that will be the lower. Third important thing is that in Erb's palsy, what are the muscles that are involved? Okay, first of all, you tell me in Erb's palsy, how will the patient look, guys? What will be the arm position of the patient? The patient arm, right? What will be the arm position of the patient? The patient arm will be adducted to the body like this, right? It will be adducted and it will be medially rotated. Why the muscle? Why it is adducting? Yes, let us say, why are you only able to flex your hand? Because your extensors are not working. That is the reason why you cannot extend, you can only flex. Vice versa, why are you only able to extend your hand? Because your flexors are not working. The same way, why are you able to only adduct your hand? Because abductors are not working. Abductors will raise your hand in this way, right? Will cause abduction in this way. So if abductors are not working, then the hand will be adducted to the body, right? So in Erb's palsy, what are not functioning? The first important thing is that abductors are not working. Not only abductors. So in this patient, if the abductors are not working, the hand is always adducted to the body. Next important thing is that, so first important thing I told you that your arm cannot be abducted. That is the reason why it is adducted. Your arm cannot be lateral rotated. That is why it is medially rotated. Next important thing is that this is called pronation, this is called supination. This is called pronation, this is called supination. Now in the patient's case, what is happening, guys? The patient's arm is becoming like this, right? So the patient's arm is pronated, or I can also call it as medially rotated. This is called supinated, or I can also call it as lateral rotated. This is called pronation, this is called supination. Pronation or medial rotation, supination or lateral rotation. So in this patient's case, what is happening? The arm is getting pronated and medially rotated. Why medially rotated? Because lateral rotators are not working. Why pronation is happening? Because supination cannot happen. Why pronators are working here? Because supinators cannot work here. That is the reason why pronators are working. So can I also write one more point, that patient supinators are also not working. Supinators are also not working. Now based upon this, I will write few muscles, guys. Look here. Biceps. Now what is the function of biceps, guys? Tell me. Biceps is responsible for flexion as well as supination. Flexion as well as supination. Now here in patient, supinators are not working. It means biceps is not working. So can I tell in Klumpke's, in Erb's, there is a problem with the functioning of biceps? Yeah. So loss of flexion and supination function. Loss of flexion as well as supination function. Next important thing, coming to deltoid as well as supraspinatus. Okay, coming to deltoid and supraspinatus. Now what do these muscles do? See, supraspinatus comes all the way like this. Deltoid is also present. So both of these muscles, they perform a similar function, that when I am contracting here, my arm is abducting in this way. So what did I tell you? In this patient, abductors are not working. Okay, so the deltoid as well as the supraspinatus muscles are also not working. So that is the reason why there is loss of abduction. There is loss of abduction. Next important thing is that the infraspinatus infraspinatus muscle is also not working. You know what does infraspinatus do? Infraspinatus will laterally rotate the arm, but here in the patient there is medial rotation of arm. I already told you why there is medial rotation, because lateral rotators are not working. What is an example of lateral rotator? Infraspinatus. Okay, so infraspinatus, because lateral rotation of arm. Okay, so there is loss of lateral rotation of arm by infraspinatus, there is loss of abduction by deltoid and supraspinatus, and there is loss of flexion and supination by the biceps. So if this was the question that was asked, that what are the muscles that are involved in case of Erb's palsy? One is biceps, next you have got the deltoid supraspinatus, and thirdly you have got the infraspinatus. Okay, so this is very important. Now when it comes to third important point on the Klumpke side, when it comes to the Klumpkes, what muscles are involved is that all the intrinsic muscles of your hand, okay, all the intrinsic muscles of your hand are involved here. Okay, so in Erb's palsy I told you what will happen, right? The fourth important thing is what will happen to the patient in case of Erb's palsy. So in Erb's palsy you will see adduction of arm, medial rotation, adduction as well as medial rotation of the arm, adduction as well as the medial rotation of the arm, right? When it comes to the Klumpke's palsy, so what do you see in case of Klumpke's palsy? The hand becomes like this. This is called as a claw hand. This is called as a claw hand. So remember one very important point, guys, that I told you previously, that ulnar claw is because of ulnar nerve, right? So here claw hand, in the sense the hand becomes like a claw like this, right? So here two nerves are involved. One is ulnar nerve along with the median nerve. The ulnar nerve as well as median nerve, both of them are involved here. Okay, both of them are involved here. Now in this patient, now in case of ulnar hand or ulnar claw, what is the important thing you will find? What is the important thing is that patient's hand becomes like this. So now you tell me, what is the position of this arm, guys? So these are called as metacarpophalangeal joints, right? This is metacarpals, these are phalanges here. So this joint is called as an MCP joint or metacarpophalangeal joint, right? Now the metacarpophalangeal joints are extended. This is called flexion of metacarpophalangeal joint. This is called flexion of metacarpophalangeal joints. This is called extension of metacarpophalangeal joints. So patient is having extension of metacarpophalangeal joint and flexion of interphalangeal joints. Okay, so that's what makes you a claw hand. So two things happening in this patient. One is extension of metacarpophalangeal joint, MCP joint, and second thing is flexion of interphalangeal joint. Okay, two important things. One is extension of metacarpophalangeal joint, flexion of interphalangeal joints. And next very important thing is that, guys, this was a question that is again and again asked, that in case of Klumpke's paralysis, there is a problem. So I told you in Klumpke's paralysis involvement of C8 till T1, right? So if you look at this T1, now when it comes to the T1 is a segment of spinal cord, right? T1 is what? T1 is a segment of spinal cord. Spinal cord has got two rami. One is called as a gray ramus, another one is called as a white ramus. All of you know that, right? It has got gray ramus and it has got white ramus. For example, if the white ramus of T1 is injured, for example, if the white ramus of T1 is injured, so if the white ramus of T1 is injured, this would lead to a problem, and that is called as Horner syndrome. That is called as Horner syndrome. So whenever you look a patient of Horner syndrome, guys, these are the following features which you would find. One is there is a drooping of the eyelid. Drooping of the eyelid is called as ptosis. Next important thing is that the eyeball, the pupil constricts. When the pupil constricts, it is called as miosis. And next important thing, patient will have anhidrosis. anhidrosis. Actually, the anhidrosis part, anhidrosis means there won't be any sweating, loss of sweating. That will be only on one side, unilateral anhidrosis. Okay. Next important thing is that patient will also have anophthalmos. Anophthalmos, right? So if you find these features, okay, so if you find these features, then the patient is said that he is having Horner's syndrome. Clear? This is having, the patient is having Horner's syndrome. And we are done with the discussion of Erb's as well as Klumpke's, guys. So the first important points we have discussed was reasons. Here there are two reasons, here there are two reasons. Next important thing is that upper trunk C5, C6, lower trunk C8, T1. Third important thing is, remember the position of the patient, right? Remember the position of the patient, and that will give you an answer that what muscles are not working. Okay, abductors are not working, so patient is adducted. Lateral rotators are not working, so patient's hand is medially rotated. Supination is not working, that is there is pronation, hyperpronation in this patient, right? Here all intrinsic muscles of hand are involved. And here the muscles which are involved are biceps, deltoid, supraspinatus and infraspinatus. Then what is the nerve that is involved? If you look at what is the innervation of biceps, deltoid, supraspinatus and infraspinatus, you will know what is the muscle nerves that are innervating them. Here the nerve that is involved is ulnar nerve as well as the median nerve. So patient's claw hand, right, put it in the form of a claw, you will understand that all the interphalangeal joints are flexed, metacarpophalangeal joints are extended. Okay. So white ramus of T1, this was a question that was repeatedly asked, that would be Horner's syndrome. Okay. Now, one very important question, which was two important questions which are again asked. What are these two important questions is that we have got roots, we have got trunks, then we have got divisions, then we have got cords. So we have seen roots are giving branches, everything is giving branches, but out of these four, there is one thing that do not give any branch at all. That is nothing but your divisions. Okay, so divisions do not give any branches. Divisions do not give any branches. What happens to the divisions? The divisions, they do not give any branches at all. Okay. Now, when it comes to the arterial supply of brachial plexus, so which arteries are supplying brachial plexus? There are only two arteries. There are only two arteries in this area. What are those two arteries in this area, guys? One is the subclavian artery and the other one is the, not axillary artery, subclavian artery as well as the vertebral artery. Okay. So if you write down the arterial supply, okay, so the arterial supply to brachial plexus, from where does the arterial supply to brachial plexus come? From the subclavian artery. Okay, and next we have got the vertebral artery, subclavian artery as well as the vertebral artery. So this was also a question asked. And remember that the arterial supply to the brachial plexus is not from the carotid arteries. Okay, it is from the subclavian as well as the vertebral arteries.